Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is congenital cardiac anomalies and this is part 1 and this is just an introduction. It's interesting that the first congenital heart defect was actually described by Leonardo da Vinci in 1531 and he identified an atrial septal defect. The learning objectives for this Part 1 Learn Shop are just to review some of the common terms that might be used and some of the etiology as to why these cardiovascular anomalies could occur. We'll review the embryonic cardiovascular development and then look at the fetal circulation and the perinatal circulation. Now worldwide there are approximately 8 to 10 in 1,000 live births that result in a pediatric having a congenital heart anomaly. It's about 0.8 to about 1% globally. Of that, there are approximately 8 anomalies that account for about 80% of all congenital cardiac anomalies. The ventricular septal defect accounts for about 33%, an atrial septal defect 8 to 9%, pulmonary stenosis 7 to 8%, patent ductus arteriosus 7%, coarctation of the aorta 6 to 7, aortic stenosis 5 to 6, tetralogy of Fallot 5, and transposition of the great arteries about 4%, the remainder being around about 0.4 to about 4%. These are the common anomalies. There are many more, as you'll see as we go through this course. Now, the etiology essentially tends to be genetic predisposition being the major cause, which is approximately 80 to 90%. It's biological, it's inherited. Chromosomal inheritance about 5 to 10%, and this can include syndromes such as Marfan syndrome, Down syndrome, Turner, Noonan, DeGeorge. There are many others. It could be related to tetragenic causes, about 1%, and this is related to maternal diabetes mellitus, maybe contamination with rubella, ingesting alcohol in the first trimester, as well as drugs and cigarette smoking. Then you've got how they can be classified. Now, congenital cardiac anomalies can be classified according to what part of the heart is affected. I haven't mentioned globally, because globally it could include syndromes like Langowan-Levine syndrome, which is a cardiac anomaly. There are numerous, so I've subdivided them into specifics such as right heart anomalies, such as tricuspid valve stenosis or atresia, pulmonary valve stenosis. Left heart anomalies could include mitral valve stenosis, valve atresia, aortic valve stenosis and atresia, coarctation of the aorta. Then they can be classified according to what type of shunt they have. So therefore it can be a left to right shunt, where you get mixing of deoxygenated blood with oxygenated blood, left to right. Right to left, where you get mixing of deoxygenated blood into the oxygenated blood, right to left. Then it can be the effect of the shunt, and this could be related to A-cyanotic disorders, as we'll see in future courses, which results in pink skin despite having an anomaly, or cyanotic disorders, which results in blue skin, deoxygenation. So here's an example, tricuspid valve stenosis, and as a consequence of the valve being stenosed, blood doesn't move very effectively from the right atrium through to the left ventricle, through to the pulmonary artery. Then you've got tricuspid valve atresia. And tricuspid valve atresia just means the tricuspid valve didn't work properly. It didn't develop properly. And as a consequence of that here, there may be an associated atrial septal defect, and there may be a right ventricle, because it's very important. Blood flow moving through the circulation embryonically is what forms and shapes the heart and the cardiovascular system. And this could be associated with a ventricular septal defect as well. Then you've got pulmonary valve stenosis, and as a consequence of that, the pulmonary valve is small, and this usually results in pulmonary artery atresia, or underdevelopment as a consequence. Then you've got left heart, mitral valve stenosis and atresia. And similar situations as compared to the right. The mitral valve is stenosed, and as a consequence of that, blood doesn't move terribly well from the left atrium through to the left ventricle, and this could result in underdevelopment of the left ventricle and possibly even the aorta and valve. Then you've got aortic valve stenosis and atresia, underdevelopment of the aortic valve, which could result in atresia, of the aorta as well. Essentially, blood isn't moving very effectively through the heart as a consequence of all these valve stenoses. Then you've got coarctation of the aorta, and there are several types which we're not going to discuss in this part of the course, but we will discuss in others related to A-cyanotic heart disease. But the defect essentially is in the aorta, and it can be in the ascending arch, it can be in the mid-arch, it can be in the descending arch. It can be preductal, it can be postductal. Here's just some examples in relation to what could happen with coarctation. Coarctation just means you've got narrowing for a specific reason, underdevelopment. Then you've got a hypo-plastic left heart syndrome. And hypo-plastic left heart syndrome is a really complex cardiac anomaly, which we will discuss towards the end. This is quite a severe cyanotic heart disease problem. But essentially, as it indicates in the diagram, you've got no left ventricle, or you've got a really severely underdeveloped left ventricle. As a consequence of that, there's no aortic valve, or there's a severely affected aortic valve. You've got aortic arch ascending atresia, which means the aortic arch just didn't develop. So essentially what you've got is just one side of the heart working, which is the right side of the heart. The left essentially doesn't exist, which is problematic, because again, if the infant doesn't get some sort of treatment at birth, they will die immediately. Then we have shunts. You can have a left to right shunt, which basically means blood from the left side of the heart is being allowed to flow into the right side of the heart because of anomalies that didn't resolve during embryonic development. So the anomaly in this situation is an atrial septal defect. And in the atrial septal defect, this one is showing you a left to right shunt. Oxygenated blood coming back from the lungs is now being shunted, sure, into the left ventricle, but some is going into the right atrium, mixing. You can also have a ventricular septal defect, where you've got left to right shunt. Oxygenated blood mixing with deoxygenated blood. You can also have a right to left shunt, and this typically results in cyanotic congenital cardiac anomalies. And there's an example here with tetralogy of Fallot, which we're not going to discuss at this point in time, but what you've got is blood deoxygenated going from the right side, the right ventricle, through to the left ventricle and being allowed to be pumped out into the systemic circulation. Tetralogy of Fallot has got numerous defects, which we're not going to discuss at this point in time. This is just mentioning and giving you an idea of right to left shunt. Right to left shunt essentially means deoxygenated blood mixing with oxygenated blood. You've got a condition called transposition of the great arteries. And in this situation here, the aorta is doing the job of the pulmonary artery, and the pulmonary artery is doing the job of the aorta. This is a life-threatening condition which results in cyanotic conditions. And again, unless there's some sort of immediate intervention here, the infant will typically die. Then you can have combined problems, where you've got right and left shunt, going from the right side to the left side to the right side. And this again is a very complex cardiac anomaly, which we'll be discussing later on in the course. Other parts. A-cyanotic basically means the infant is pink. The infant is well perfused. They still have a problem. Here's just one example of patent ductus arteriosus, but there are numerous others. Then you've got cyanotic, which results in an infant who is really blue, a blue baby. And this could be tetralogy fellow, but there are numerous others as well. Let's review briefly so you have an idea of where this all happens. And during embryonical development, this is just a brief overview. So put it into your mind, 18 days post-conception. This is the embryo here. Look at number 9. This is approximately 18 days post-conception, and you can't even see the embryo, but already the heart is working. So 18 days post-conception, already the cardiogenic area is developing with primitive blood vessels, and this is essential. This is essential because, again, it's the cardiovascular circulation and the heart pumping that promotes development of all the embryo's organs. Approximately 20 to 22 days post-conception, this is what you're looking at. Here you've got endocardial tubes developing, there's fusion of the primitive heart tube, and you start developing the truncus arteriosus, bulbus cordis, the primitive ventricle, and the primitive atrium. Approximately day 23, day 35, already the heart is starting to look externally what the heart should start looking like. So looking at it, about 23 to 35 days post-conception, the bulbus cordis, which basically means the big part, there's a common ventricle, there's a right atrium, left atrium, there's a truncus. The truncus arteriosus, of where most of the arterial components are developing, and you've got a sinus venosus, which is where most of the sinus or most of the venous components are developing. It's twisting and moving constantly to get into the right position. Same, 23 to 35 days, it's turning and it develops what is called the bulboventricular D loop, and it bends to the right. It shouldn't bend to the left. If it bends to the left, you'll have an anomaly. Truncus arteriosus is forming, the common ventricle is forming, the right and left atrium are forming. This is going to be the future right ventricle and the future left ventricle. But you're only seeing the external components. We'll look at the internal components shortly. So what you can appreciate, it's a complex process that has to follow a specific chromosomal path. If it doesn't, then the heart won't develop and the cardiovascular system won't develop effectively. Day 23, day 35, post-conception, the bottom of the heart, cardiovascular, twists up. The top part twists down. And now we're starting to see something that resembles the truncus, which contains the pulmonary artery and the aorta, the common atrium, right and left, the common ventricle, right and left. So now, approximately day 35, the exterior is almost complete. It's starting to look like something that we know. Inferior vena cava, superior vena cava will connect at the top into the truncus. You've got a common atrium, right and left. You've got a common right ventricle, common left ventricle. They're still not unique in the sense that they have a septum, but you're only seeing the external parts at present. So approximately day 28, day 32, we start getting the interior developing. So this is the atrial septal formation, and you've got specific pathways. First of all, we start with the common atria. As we mentioned, we saw that earlier. And what ends up happening is the septum primum, the first septum, begins to grow. And there creates an ostium primum, the first opening between the atria. Then you've got the septum primum closes with the ostium primum. So it actually closes. So there's no communication between right and left. And failure to fuse causes an ostium primum defect, which is an ASD, an atrial septal defect. which we'll be discussing as we go through other courses that you may consider attending. Approximately midway, day 30, the septum primum is absorbed and the ostium secundum, the second opening, appears. The septum secundum grows on the right side, and this will be the future foramen ovale. The septum secundum covers the ostium secundum, the second opening. So it's like a little doorway. It's like a little one-way valve. And failure to cover causes a second atrial septal defect called the ostium secundum defect, the second type of defect. If we look at the ventricle now, approximately day 32, day 42 post-conception, the ventricle septum forms. When we look at ventricular septal formation, we commence with the common ventricle, just as we did with the atria. There's no septum. However, approximately day 32, the muscular ventricular septum or septation begins. It continues until ventricular septum formation in relation to the muscular part is almost complete. If it doesn't complete and failure results, this results in a muscular ventricular septal defect, which we'll be discussing when we look at A-cyanotic congenital cardiac anomalies in other courses. As it moves on to close the upper portion of the ventricular septum, the perimembranous septum forms, and failure to do that results in a perimembranous VSD, ventricular septal defect. During this phase as well, you get truncus septation, which basically means the big trunk, which contains the future aorta and pulmonary artery, start to separate, and they twist and turn into the appropriate position. And failure to separate results in common trunk physiology, which basically means the aorta and pulmonary artery are one, a truncus, which we'll be discussing when we look at A-cyanotic anomalies. As I mentioned, the aorta is supposed to twist and the pulmonary artery is supposed to twist, but they have to twist the right way. The aorta twists to the left, the pulmonary artery is supposed to twist to the right. If it doesn't twist the right way, then this results in what is called dextrotransposition of the great arteries, DTGA, which basically means the aorta is on the right side, dexter, and the pulmonary artery is on the left side. Transposition of the great vessels, transposition of the great arteries. At this time as well, the ventricular septum, the opening at the perimembranous region, closes with some conal swelling and development. Failure also results in a perimembranous ventricular septal defect. And what should happen is the aortal truncus twists to the posterior and the pulmonary artery truncus twists to the anterior, and as a consequence of that, this is the final event that causes the ventricular septum to close. Now we want to conclude with the cardiovascular development in relation to other vessels that are associated with the heart. So approximately day 30 to day 50 post-conception, 30 days, 6 pairs of aortic arch vessels develop. At 50 days, there are 2 aortic arches. There's a brachiocephalic artery with a left subclavian artery and a right subclavian artery, a left common carotid and a right carotid artery. You've got the pulmonary trunk, you've got the right pulmonary artery and the left pulmonary artery, but you have 2 ductus arteriosi. And it's complex. Here we have our 2 aortic arches, which are ascending. We have 2 descending aortas. We have a right and a left aortic arch. And as I said, we have 2 ductus arteriosi. During this developmental phase embryonically, lots of things can happen, which we'll be discussing when we look at future Learn shops. You can end up with a hypoplastic aorta, an interrupted aortic arch, a right-sided arterial arch. You can have a hypoplastic ascending aorta. You can have a left-sided aortic duct. You can have lots of anomalies that occur during this phase, which is problematic. You can have the wrong coronary arteries implanted incorrectly. So everything has to follow a specific pathway, otherwise we don't end up with the heart or the cardiovascular system, which relates to all other organs in the body. Approximately day 30 to day 50, these are the cardiovascular changes that should occur. The right aortic arch should be absorbed, so we're left with a left aortic arch. The right descending aortic arch is absorbed, so we only have one, the main descending aorta. Approximately 56 days post-conception, the cardiovascular system changes and is complete. And this is what it should look like with our aortic arch, our pulmonary artery. We should have the right external carotid artery, left internal carotid artery. We should have the right subclavian artery and the left subclavian artery. We should have an ascending aorta, an arch, a descending aorta. We should have the pulmonary artery. And everything should be in the right place. And eventually, after several weeks, we should have a ligament arteriosum, where the ductus arteriosus was. So 56 days, we have one aortic arch, the brachiocephalic artery, the left subclavian and right subclavian artery, the left common carotid, the right common carotid artery, the pulmonary artery and its trunk, the right pulmonary artery, left pulmonary artery, and one ductus arteriosus. And this now is the fetal circulation pre-birth. Pre-birth, we have the placenta, we have the ductus venosus, we have the ductus arteriosus, we have the foramen ovale. So, we have the placenta, which is the lifeline from the mother, maternal circulation, to the fetal circulation. We have the ductus venosus that shunts blood away from the liver, which isn't really working, up into the inferior vena cava into the right atrium. We have the ductus arteriosus, which shunts blood away from the lungs because the lungs aren't really working. So therefore, what ends up happening is the blood has to be shunted back towards the placenta, because the placenta really is the lungs of the fetus. And then we have the foramen ovale, which again shunts deoxygenated blood from the right side to the left side, so it can be returned to the placenta and be reoxygenated. After birth, there are some changes. The forced shunts cease because the placenta is no longer connected to the fetus, which is now not a fetus, but a newborn infant. So the placenta is immediately gone, which means the heart actually is in for a shock. It has to start working even harder now, because the placenta is no longer supporting it. The ductus venosus closes within days to weeks, and it becomes the ligamentum teres. The ductus arteriosus closes immediately, well, sort of, but it takes several weeks. And as a consequence of that, it becomes the ligamentum arteriosus. The foramen ovale closes immediately and eventually becomes the fossa ovalis. These are the changes that occur in the newborn circulation. Placenta is disconnected. Ductus venosus closes. Ductus arteriosus closes. Foramen ovale closes. That's the end of part 1. Thanks again. Thanks for following Dr. Manny Annie's Learn Shops. This is part 1, congenital cardiac anomalies. Now move on if you found this of any value to you, to part 2. And please recommend it to your colleagues if you think it's of any value to you. See you in part 2.